We'll now hear from a cube called Data-Driven Tools to Curb the Spread of Healthcare-Associated Infections. Bringing together faculty from the College of Engineering and the medical school, this cube also includes graduate students and fellows from medicine, engineering, and public health. Let's welcome Professors Vincent Young and Evan Snitkin and graduate student Janine O.
So I'm Vincent Young. I'm from the Department of Internal Medicine, the Division of Infectious Diseases, and I'll tell you about our cube today. So if I ask you to think about a physician, what image comes to your mind? Perhaps it's something like the physician in this famous painting. I must admit, when I started medical school over 30 years ago, this is what I thought I was training for, to become the master clinician. Someone, through his powers of observation, could make a diagnosis, explain it to a patient and the patient's family, and perhaps most importantly, intervene in the patient's illness. As I continued my training, I really understood why the mother in this painting was so upset. She's obviously concerned about her child who looks like she's suffering from an infectious disease. But she's probably also shocked by the fact that the physician could basically do nothing to help her child. It was around this time that physicians understood that many of the diseases that they actually were trying to treat were caused by infections with microbes. But it was really not until about 50 years later that they could actually do something to intervene when antibiotics came in widespread use. It was actually thought that the advent of antibiotics would mean the end of infectious diseases as we know it. Unfortunately, we know that's not true. Antibiotic resistance has risen, and now we actually might be in the post-antibiotic era. We have infections that we cannot treat with any of our currently available antibiotics. So we want to try to stay ahead of the infections. We've tried to study the pathogens. How do they make us ill? What are the defense mechanisms that the host has to try to prevent disease? And importantly, over the past few years, we've come to realize that we are actually host to myriad microbes that live in and on us. These are our normal microbiota. Together with their environment, and the whole thing we like to refer to as the microbiome, all of these microbes profoundly influence our health. But like the physician in the painting, it's made me think. I realized that with such a complicated system, something that I didn't learn about when I was in medical school and training, I didn't actually have the skills and expertise to understand this complex problem. Fortunately, the MCubed initiative gave me the opportunity to find up-and-coming investigators on this campus who could help me make sense of this complicated situation. Evan Snitkin in the Department of Microbiology and Immunology, and Jenna Weens in Computer Science and Electrical Engineer had the skills to help me understand the complex interaction between microbiome, pathogen, and the host. I'll turn the stage over to Evan to tell you more about our specific project.
As Vince alluded to, antibiotic resistance is among the most pressing public health threats of our time, affecting the developing and developed world alike. Infections that were once routinely treated with antibiotics are becoming increasingly difficult to treat because of resistance. And while resistance to individual antibiotics is concerning, what the greatest concern has been the emergence of multi-drug resistant organisms, some of which are resistant to virtually every antibiotic that we have available. These multi-drug resistant organisms have come to permeate global healthcare networks, causing life-threatening infections among some of our most vulnerable patients in intensive care units of hospitals. With antibiotics being available to treat these multi-drug resistant organisms becoming more limited, it's essential that we understand how to more effectively prevent these infections from happening in the first place. The most common cause of healthcare-associated infections in the United States is the bacteria Clostridium difficile, or C. diff for short. The CDC estimates that Clostridium difficile is responsible for 250,000 infections per year in the United States alone, and this is associated with 14,000 deaths and upwards of $1 billion in associated medical costs. In addition to being resistant to multiple antibiotics, C. diff infections is intrinsically linked to antibiotic use, as antibiotic use is a major risk factor for C. difficile infection. Work over the past several decades has determined that the reason why antibiotic use is a major risk factor for C. difficile infection is because of the collateral damage that antibiotics impose on the normal bacteria that inhabit our gut, which normally protect us from invading bacterial pathogens. In particular, upon antibiotic treatment, the normal bacteria that inhabit our gut, or the microbiome, are damaged. And this makes our microbiome susceptible to invading pathogens, such as C. difficile. Upon entering our gut, C. difficile can then grow to larger numbers and ultimately produce the C. diff toxin. And this toxin can then lead to severe and potentially life-threatening gastrointestinal disease, leading to serious illness in patients. However, while we understand in general terms how this infection process unfolds, we lack a sufficiently nuanced understanding to be able to predict, for an individual patient with a given medical history and microbiome configuration, what will happen when they're exposed to a given strain of C. difficile. Will they remain healthy and go about their normal life, or will they contract a severe disease that could potentially become life-threatening? And this sort of really detailed understanding of the disease process is what we seek, as we believe that it will empower us to identify and protect patients who are at greatest risk for contracting these serious diseases. For our Cubed, we sought to take the first step in this direction by leveraging the entire context of the electronic medical records of patients at the University of Michigan Hospital to attempt to predict which patients were at greatest risk for contracting severe C. difficile infections.
Hi, my name is Jihei, and I'm a graduate student working with Professor Jenna Weens on the C. diff project. So, although these infections are stubbornly pervasive, they are also relatively rare. So on any given day, out of the 1,000 patients at Michigan, only 3 of them will contract an infection with C. diff. So how do we accurately identify these 3 individuals in advance of their infection? One of the ways we can do this is to leverage the data that we are already collecting on a routine basis. So on an average day, a single patient will populate 10,000 data points. This includes what medications they're on, what procedures they had done, what locations they're at, and what lab tests they had run. However, this is a lot of data. And with so many variables, it's impossible for the human mind to process all this information for one patient, let alone 1,000. But we're in luck because that's what machines were built to do. So given large streams of data, using machine learning, we are able to identify the patterns that are predictive of high risk. So much like Neo from the movie The Matrix, we are now able to see our world differently. We are able to spot the correlations between locations and medications with the incidence of C. diff. And this helps inform us about how C. diff is being transmitted and also what makes patients susceptible to the disease. These insights drive hypotheses and help fuel future research and testing. Lastly, these insights and patterns help us predict the future and find the needles hidden in the haystack. So using these identified patterns, given a new patient, our algorithm will produce daily estimates of risk. And once this risk passes a predefined threshold, we determine that this patient may benefit from an intervention. So to recap, we have taken data that are already being collected during a patient's hospital visit, and we have used it to automatically identify those patients most likely to get the infection, and therefore most likely to benefit from risky or costly interventions. Our method uses the whole electronic health record, and by doing so, it is able to outperform more traditional methods and not use narrow assumptions about which features are most important. Our data-driven approach can be applied to different hospitals, resulting in risk estimators that are tailored to a specific institution's layout, clinical protocol, and population.
So what can an old infectious disease do now that he has collaborators that can make sense of all of this data that we get from our clinical care and from our biomedical research? Well, you heard from Dr. Collins already that we were able to leverage the start that we had with the Cube to successfully compete for an NIH grant that challenged researchers to use a systems biology approach to study infectious disease. With this ongoing collaboration, we hope that we will not only understand what's going on with our patients, we'll be able to come up with new tools to treat and prevent this infection as well as many other infectious diseases. Thank you.